السلام عليكم ورحمة الله وبركاته. I am Dr. Raga, anesthesiologist at State University Hospital and American Heart Association faculty. My lecture today is about airway management. We have to revise together airway anatomy. Do you remember that upper airway consists of nose and mouth, pharynx, epiglottis, glottis, and lastly the larynx. At the level of the vocal cords, lower airway starts from trachea to bronchi, bronchioles, alveoli, lung tissue, lobes and lobules, and lastly. There are many maneuvers we use to open the airway, starting from head tilted to left. This is the main way, and if we suspect cervical spine injury as in trauma patient, we have to do jaw thrust. But remember, if jaw thrust failed to open the airway, we have to do head tilted to left with manual inline stabilization of the neck over the chest. To maintain opening the airway, we have to use adjuncts. The available adjuncts are oropharyngeal airway, nasopharyngeal airway, laryngeal mask airway, and lastly the endotracheal tube. We will discuss them in details. First of all, oropharyngeal airway, OPA. The proper size of oropharyngeal airway is measured from the corner of the mouth to the angle of the jaw. It has many sizes, ranges from 0 to 6. It holds the tongue away from the posterior pharynx but does not isolate the trachea. This is the proper size of the oropharyngeal airway from the corner of the mouth to the angle of the jaw. This is how to insert the oropharyngeal airway. The oral airway is inserted with the curve towards the side or the upper part of the mouth. When we reach the junction between the hard palate and soft palate, it's rotated so that the curve of the airway matches the curve of the tongue. Contraindication of insertion of the oropharyngeal airway is conscious patient because it stimulates the gag reflex and the patient is liable to vomit and aspirate. These are different sizes of oropharyngeal. This is how to insert the oropharyngeal airway. 2. Nasopharyngeal airway. It's a rubber tube that is designed to bud just inferior the base of the tongue. To reach what? To reach the nasopharynx only. It passes through one of the nares and can be used in patients with intact gag reflex. So we can use nasopharyngeal airway in conscious patient, semi-conscious patient, and completely unconscious patient. It's contraindicated in cases of suspected or possible basilar skull fracture. And how we suspect basilar skull fracture in a patient? Many signs: otorrhea, rhinorrhea, raccoon eye, and battle signs on the mastoid process. There are many contraindications for nasopharyngeal airway, including coagulopathy or bleeding tendency, and also it's contraindicated in patients with nasal fracture or paranasal sinus fracture. How to measure the proper size of nasopharyngeal airway? It's measured from the tip of the nose to the corner of the patient's ear. These are different sizes of nasopharyngeal airway. This is the proper size of the nasopharyngeal airway. This is how to introduce the nasal airway. The nasal airway is lubricated with water-soluble lubricant. The bevel tip is inserted directed towards the septum with the nasopharyngeal airway directed perpendicular to the face. If resistance is met, rotating the nasopharyngeal airway may help, or the other nostril may be. 3. the laryngeal mask airway, LMA. This is the laryngeal mask airway. It sits over the glottic opening. Also, it's available in different sizes and has a drain tube to aid in gastric suction. These are different sizes of LMA. This is how to introduce the LMA. Proper position of the LMA sits over the walls. 4. Endotracheal tube, ETT. It is the preferred method of airway control. It has many benefits. It isolates the airway. It allows for ventilation with 100% oxygen. It decreases the risk of aspiration. It facilitates deep tracheal suctioning, prevents gastric inflation during ventilation, and also it's used as an additional route for drug administration. This is the endotracheal tube composed of a tube, curved, with a cuff as the distal end. This cuff is attached with inflating tube, pilot balloon, and one-way valve. And the upper end or the proximal end is connected to the ventilator. These are different sizes of endotracheal. What are the indications for endotracheal intubation? ETT is used in patient who is unable to protect his airway, in patient with oxygenation problem requiring high concentrations of oxygen because it can provide up to 100% oxygen. Also, it's used in patients with ventilatory impairment requiring assisted ventilation. Complications: hypoxemia, trauma to the airway with hemorrhage, esophageal intubation, vomiting leading to aspiration, loose or broken teeth, and lastly, it may injure the vocal cords. To insert an endotracheal tube, we have to use many adjuncts. First of all, laryngoscope. Laryngoscope has different sizes with different shapes of blades. It consists of a handle and a blade, and the blade has light source. Also, for insertion of endotracheal tube, we need different sizes of tube: forceps McGill, oropharyngeal airway, forceps artery, and a syringe. This is the endotracheal tube in place. Any questions? Many thanks.